Hi, and welcome to our educational video series from the Department of Interventional Pulmonology, SSM Health, St. Mary Hospital, in Madison, Wisconsin. In this video, I'm going to discuss the burden of lung cancer, the importance of lung cancer screening, and briefly touch base on the robotic-assisted bronchoscopy that is the latest modality for the diagnosis of peripheral lung nodules. As we all know, lung cancer is a big public health issue. It remains the most common cause of cancer-related death in both men and women, and is the second most common cause of cancer after prostate cancer in men, and breast cancer in women. While it is not always possible to identify the cause of patients' lung cancer, tobacco use is the leading risk factor for lung cancer. The smoking rate in the state of Wisconsin is not significantly different than the national rate, that is 14%. Radon is the second leading cause of lung cancer. In Wisconsin, 46% of radon tests results were at or above the action level recommended by the U.S. Environmental Protection Agency. This important slide shows the stage at diagnosis with lung cancer, and the 5-year survival rate corresponding to each stage. Let's start with the stage at diagnosis. The top data shows only 26% of patients with lung cancer are diagnosed at an early stage. The remainder of the patients are either unstaged or diagnosed with advanced or metastatic lung cancer. As we know, the clinical outcome of lung cancer is directly related to stage at the time of diagnosis. The bottom data shows the 5-year survival rate. You can see it drops down significantly with later stage of cancer and is only 7% for stage 4 disease. How can we shift colors? Or stage shift, and diagnose more patients in early stage? Which mean having more people in the dark blue colored box. The good news is that we have a tool now, which helps us diagnose more patients in early-stage lung cancer and improve survival. In 2011, the landmark clinical trial on lung cancer screening using low-dose CT was published in the New England Journal of Medicine. The National Lung Screening Trial, or NLST, was a randomized controlled trial of more than 50,000 patients, which compared the effectiveness of low-dose CT compared to chest X-ray in high-risk patients in developing lung cancer. Those patients were at high risk in developing lung cancer if they were between the ages of 55 and 74, and they were current or prior heavy smokers. These patients were randomized to either a yearly chest X-ray or a yearly low-dose chest CT, each year for a total of 3 years. The study showed a relative reduction in lung cancer mortality with low-dose CT of 20%, with a number needed to screen of 320. Unfortunately, lung cancer screening has been poorly adopted. In Wisconsin, only 10% of those at high risk were screened, that is higher than the national rate of 6%, but still low, and we need to do better. Rates vary tremendously between states. This may be because of a lack of access or low awareness and knowledge among patients and providers. The guideline did undergo few updates since its implementation in 2013. The change affected age and smoking history. The age of screening was decreased to age 50 and the amount of smoking was decreased to 20 pack year. These changes helped include the minorities and underserved population. When discussing lung cancer screen with a patient, it is important to not only discuss the benefit of screening but also discuss the potential harms of low-dose CT. The patient may ask, what is a positive screen? It is non-calcified nodule greater than or equal to 6 mm. Discuss how is it managed, and potential complication rate if undergoing a procedure. Inform what is the false positive rate, that is 96%. Discuss overdiagnosis, that is detecting indolent cancer or cancer that are not lethal. Discuss possible incidental findings. Low-dose CT requires very small doses of radiation. The risk of harm from this radiation exposure is low. If meeting the criteria set by CMS, the cost is paid by the patient's insurance. Following low-dose CT, the radiologist uses a classification called lung RADS, a tool designed to standardize lung cancer screening CT reporting. Each lung RADS category has a follow-up plan associated with it, to help physicians appropriately manage the patient. Lung RADS include standardized categories. Every category will receive one number, and some will receive a number and a letter. The lung RADS is used exclusively for the screening population, not for incidental nodule or low-risk patients. For lung RADS 1 and 2, the low-dose CT is read as either negative or benign, and a 12-month screen low-dose CT is recommended. Lung RADS3 means we are probably dealing with benign finding. Patient should have a follow-up low-dose CT after 6 months. Lung RADS4s report suspicious findings that need close attention. Recommendations are either a 3-month follow-up low-dose CT, PET-CT, referral for a clinical evaluation or tissue sampling. The first step in managing a positive screen is to compare the finding with old chest CT if available. Based on lung RADS description, we may elect to monitor with a low-dose CT, or perform a diagnostic CT. PET-CT may be considered, if the lung nodule measures 8 mm or above. If tissue sampling is indicated, depending on where the patient is, there will be different equipment, technology and expertise available to help reach the targeted pulmonary nodule, and obtain tissue. While it is important to establish a lung cancer screening program to detect small pulmonary nodules, it is also important to be able to deliver an accurate diagnosis with minimal or no complication, and offer patient-appropriate treatment in a timely fashion, and that does not always happen. Now, I will briefly discuss the robotic-assisted bronchoscopy and focus exclusively on the ion endoluminal system, which is the latest innovation in the diagnostic approach of pulmonary nodules. The catheter has a 3.5 mm outer diameter and a 2.0 mm working channel, and can articulate 180 degrees in any direction, which means it can reach deep and hard to reach peripheral pulmonary nodules. The ion endoluminal system is the only bronchoscopy using shape sensing technology, designed to provide precise location, shape, and orientation feedback throughout the entire navigation and sampling process. It holds its position once the targeted nodule is reached and offers unprecedented stability. The flexible biopsy needle comes in 3 different gauges, and can extend up to 3 cm. The PRECISE trial is the first single-arm prospective multicenter study, evaluating the clinical utility of the ion system. Data from a small subset of patients was published as an abstract in 2021. The nodules' sizes were between 10 and 30 mm. From the cohort of subjects reported, the sensitivity for malignancy was 87% for nodules less than or equal to 2 cm, and 92% for nodules between 2 to 3 cm. There was only 1 asymptomatic pneumothorax reported in this small subset of patients. In conclusion, lung cancer remains a major public health issue. Low-dose CT screening has shown to decrease mortality in high-risk population, but we need to do better. We need more awareness around lung cancer screening. So many people who are eligible for screening are not receiving it. Adding to that, new technologies are emerging and showing high accuracy in the biopsy of small peripheral lung nodules with excellent safety profile. The goal is to detect early lung cancer in high-risk patients, provide high-value care, and decrease mortality. This concludes our video. Thank for your attention. And please don't hesitate to leave a comment or a suggestion below. Goodbye.